afternoon and welcome to the NHI webinar, the Lowdown on NHI, with me, your host, Neesa Moodley from Daily Maverick. With me today, I've got guest speakers Craig Comrie, Chairperson of the Health Funders Association, and Professor Alex van den Heever, Chair of Social Security Systems Administration and Health and Management Studies at Wits University. Welcome to both of you.
Good morning.
Good day and good to be with you.
Great. So we've got more than 900 people registered for this webinar, indicating the massive interest. I think it's one of the biggest webinars I've hosted so far. And the whole country has lots of questions. I'm not saying we're going to be able to answer all of those questions, but I'm hoping we can at least have a robust discussion about what the NHI holds for us going forward. So I think to kick it off, let's start with Alex. Can you maybe unpack for us what is government thinking? What is their logic behind the introduction of NHI?
Well, there is a stated logic and there is logic. The stated purpose is to achieve or to move toward universal health coverage and to achieve sort of efficient and fair distributions of access to healthcare through this legislative framework. The only issue there is that technically South Africa actually has universal health coverage because effectively everybody has either access to free state services or to what can be referred to as prepaid healthcare through a medical scheme. Which is underpinned by a regulatory framework that requires that certain prescribed minimum benefits must be covered, and there's protected access to the medical scheme system through open enrollment, community rating, etc. So, so that particular objective is unclear, but the objective of efficient purchasing or efficient access to services remains as one of the objectives. And it aims to achieve this by setting up a central purchaser and consolidate a central purchaser at the national level of government, which would take over, in theory, the functions of provinces and medical schemes to buy healthcare for 62 million people, the entire population. That is, at least in terms of the white paper and various other documents, the kind of stated purpose of the ultimate end objective of this framework. And obviously, issues have been raised about whether or not that framework, A, does efficiently achieve those objectives, and secondly, whether or not the achievement of a single purchaser for everybody is actually a realizable objective. But it's stated but that's what the stated kind of purpose is overall. And there's a lot to debate and discuss within that.
Absolutely. Before we get into the nitty-gritty, I think it's quite an ambitious plan that government has put on the table, and not just put on the table, but signed into law last week, 2 weeks ago. Craig, let's go over to you. What is this going to mean for medical schemes in general? I think some of the talking has been about medical schemes now moving to cover whatever is not covered by NHI, which seems to me a little bit weird because we don't know what NHI is going to cover yet.
Yeah, and that's where the problem lies. We don't have a clear indication of what benefits are included in the NHI at the moment. And so as a policy statement, it talks about the intention of equity and improving access to healthcare, which is a noble intent. The issue is, how do you get there practically? And a lot relies on the ability to fund this ambitious project. And so it's not clear exactly on what the benefits are included. And as a typical medical scheme representative, if you don't know what benefits you included, you don't know what you spend in and how much you have to spend. And so it's in that space that there's no clarity yet, but the regulations are supposed to give us information regarding that part of it. So what we have is a very clear intent in terms of policy, some issues that have to be confronted in terms of freedoms of choice, and certainly from our perspective, the role of private healthcare funders in the whole rollout of NHI needs to be clarified. But you're correct. I think for the here and now, nothing will change. The ability to fund this ambitious project is is really subject to economic growth in South Africa and stability in that economic growth space, and being able to attract additional tax revenues to actually fund an NHI like this. But the role of medical schemes is here to stay for I would say, for the next few decades, and it really is considering the fact that there is no real funding, and we are all considering constitutional challenges and some of the legal issues that need to be sorted out before it can really move and make any real difference.
So you brought up a fair number of points that I do want to touch on. Let's start with the funding issues. Alex, there have been several different numbers that have been bandied about. One of the numbers I've seen is 200 billion that was put forward by Business Unity South Africa. And the number is definitely running into billions, and it's varying wildly. What are we looking at? And how are we going to fund it? I think that's what everybody really wants to know.
Yeah, so there are a number of things to put together. So the first issue actually relates to the question you put to Craig. I mean, what is the what is the role of medical schemes? And that depends very much on the definition of what's called complementary coverage in the Act itself, which is basically about as vague as it could possibly be, and theoretically allows the minister to define, in terms of regulations, you find out after regulations what complementary coverage is. Now, this is obviously something that's going to have to be tested in the courts. Without doubt, it has to be, because the enabling provision for regulations has to be absolutely clear. And you can't come up with a set of regulations in which you find out what the definition is at the end of the day. And what it basically says is complementary coverage is whatever the NHI doesn't cover. And that's not a coherent definition. Coherent definition has to clarify exactly what complementary coverage means, because there are many ways to look at what an NHI fund could cover. So, for instance, the NHI could cover certain benefits, as a medical scheme does at the moment, and specify them. And then whatever it doesn't pay for, reimburse, is essentially complementary coverage, which effectively doesn't impact on medical schemes whatsoever. As the Act is currently framed, it actually doesn't compel anybody to become a member of this fund, the NHI fund. It has a definition of user, but it doesn't actually compel anybody to become a user. And probably this is because the idea is that it will indirectly compel people to become users by removing their ability to be covered in any other environment. So this is this is an issue as to whether or not that's actually a valid approach to take. But the idea would be to move you across because you don't have any alternatives. So this is, the movement across depends on whether or not the NHI fund actually prohibits you from covering what the NHI covers, and for that you have to have clarity. So this is the problem, is that without clearing that very issue, that particular mechanism basically falls away. So it's not terribly clear what they mean, but in terms of the white papers, there was a suggestion that in essence, all this coverage would be consolidated in the NHI fund. But when you look at the wording of the Act itself, it's not very clear. But it would be inappropriate to leave it up to the arbitrary decision-making of the minister to make such a radical decision without referring back to Parliament. So, for instance, if that definition permitted the Minister of Health to just arbitrarily define things in such a way that complementary coverage is everything that the scheme covers. So, for instance, oncology services, we cover oncology services, now you can't be covered for oncology services. You can't allow regulations to suddenly state that. So these are things that would have to be clarified. Now, just on the question of the funding, the logic of this Act appears to be, at least in terms of the way the policy framework has been adapted, that the way people move across is first of all through removing their coverage, which the Act is very unclear about, and secondly, that it would actually introduce what's called a mandatory prepayment arrangement. Now, it actually states this in the National Health Insurance Act, but this is not a money bill. And the Minister of Health and this particular Act is in no position whatsoever to impose any taxes. So that is something that is introduced by the Minister of Finance through a money bill. And if this were classified as a money bill, then it's been incorrectly tagged and is then unconstitutional, ab initio. It's basically doesn't exist. So the issue is that it's not a money bill. That would be one way of interpreting this. And therefore, a reference to mandatory prepayment in this, whatever that means, because it's not properly defined, refers to the idea that it's going to introduce some new taxes in order to finance, theoretically, the movement of medical scheme members into this fund. And on the assumption that it will actually raise probably equivalent to what medical schemes are currently spending, which is about 3.5% of GDP. That's the answer to your question. There's no costing of this framework. It's just the assumption that whatever is currently being spent will now become the money that is available to government. So this is kind of part of the problem, is that that's a pretty arbitrary approach, because you're not actually offering somebody a movement, a substitutive cover. You've just taken their money, and now you're not necessarily offering them equivalent coverage. So these are real problems in the framework. But the fundamental issue around the cost, because you've raised the issue of cost, is actually there's never been a financial appraisal of this policy. There's no document, no analysis of exactly how all these financial arrangements and institutional arrangements will actually work, and whether or not the objectives of the Act will actually be fulfilled through these mechanisms. So in fact, there's not a document, there's no analysis, nothing was presented to Parliament, despite the fact that these proposals have been in existence for since 2008. And so there is absolutely no document that spells any of this out. And yet an enormous amount of time has passed in which these kinds of analyses could have been done systematically. So this is a concern, is that when you have to ask me that question, I understand that Nicholas Crisp declined participating in this session. That would have been the question that would have had to have been posed to him. Where did you do this work? What work have you done? How do you understand that these arrangements would operate and work? And if you can't answer that question, there's a serious question about whether or not this is a proper piece of legislation. So I think there are a lot of questions that need to be answered about this legislative framework.
Yes, thank you, Alex, for bringing that up. I do think it's important for our listeners and our viewers to know that we did attempt to get Nicholas Crisp from the Health Department on board for this webinar, and unfortunately he declined. It would have been great to have somebody from government. Maybe he felt he was going to be on the spot. One of the other issues I want to touch on is the legal challenges that are being brought against this Act. I believe there are at least 6 legal challenges from Solidarity, which is the trade union, the South African Medical Association, Health Professionals Collaboration, the Democratic Alliance, and also your association, Craig, the Health Funders Association. So from your perspective, the HFA, can you talk us through what are you going to be putting on the table with that legal challenge?
Yeah, thanks. And it does go back to the constitutional rights to access health and to have freedom of choice in terms of where and how you access health. So it's not to say that you aren't going to pay the taxes that may be appropriated into the NHI system at all. It's actually to say that after that fact, you should have the rights to choose and fund on your own, and however you would like to fund it, whether it's using a third-party health insurer or private insurer, that choice should be allowed to you. And I always think sometimes we get stuck in the technicalities, but when we look at an example, the examples are very clear. So if you are pregnant and need to access the NHI, you have to register, as Alex says, you have to register as a user. If you are low risk, there's a very good possibility you get allocated to you register with a facility, a practice or an accredited provider, but you may be just referred to a midwife. If you want to then choose to go to a gynae or a different gynae that's been allocated, you have to fund it out of your pocket. But the choice is prohibitive, because the big items that you may fund for a delivery in South Africa might cost you anywhere between 20 to 50,000 Rand. You can't get a private funder or a medical scheme to cover that if pregnancy or delivery is listed as a benefit in the NHI. And so that's where the choice issue becomes very real. So either you don't follow the protocol of the NHI, which may look very similar to the public sector protocols in terms of on referring you, and it's a very good way of doing it, but it does remove that freedom of choice, and so that's the freedom of choice that people must have in terms of how they fund and how they access their health. That still needs to be protected. So there is an existing right that medical scheme members have in terms of freedoms of choice, in terms of which gynae they might use, which specialist they may use, or which hospital they may wish to go to. That existing right cannot be taken away by the introduction of an NHI, which then forces that right to be determined by the NHI fund and the protocols and rules of that fund. And so that's the right that we need to preserve, and that's the right that we would dominantly try to protect for medical schemes and those who want to choose to use their choice to access healthcare differently.
So I can't help, as we're having this discussion, I keep getting this analogy in my head of a marriage. And this, I think, ultimately would be a marriage between the private sector and public sector when it comes to the provision of healthcare. But Alex, correct me if I'm wrong, it almost seems like the government has rushed into this marriage without a prenup in place, and that's why the private sector actually doesn't know what they're getting into, really.
Well, there's a lot of things that they've potentially rushed into because it's very unclear. Many of the mechanisms that they've proposed, the intermediation that they have between this fund and the purchasing of healthcare services is extremely unclear. Essentially, they're saying we're just going to build it and then you will find out. We will provide regulations and then you will find out. But in many areas, there is actually a conflict between existing rights that exist. These include both within government itself, because it establishes structures at the national level of government, which already have equivalents at the provincial level of government. And there's no function shift. There's no movement of these functions to the national level of government. So they both coexist. And the money currently is allocated to provinces, and they have all the powers in terms of the constitution to do everything that they want to do at the national level. So that conflict is very unclear. And then in relation to medical scheme coverage, the complementary coverage that is referred to only refers to medical schemes. It doesn't refer to any other health insurance, but is in itself is a function already carried out by medical schemes. So a clear problem exists in that the overall legislative framework attempts to solve a problem that isn't a problem. In other words, we have coverage. It wants to create a third form of coverage on the assumption it will be superior to the other two. And yet it doesn't have any evaluation or analysis to show that, but also doesn't have any clear machinery as to how it will actually do it and do it fairly, justly, and efficiently, and that it would be better than the existing arrangements. But in relation to the private sector and medical scheme coverage, when you create legislation and have a clear purpose, you should have a problem that you're trying to solve. And the idea appears to be that if they're having medical scheme members having coverage is somehow harming coverage in the public sector. But there is absolutely no evidence of this. In every analysis, people paying for their own health care over and above their taxes, covering themselves, has zero impact on the public sector. Now, there could be some impact, but many of these impact, let's say there could be that there's inappropriate moonlighting. But those are all management issues that the public sector is meant to respond to and resolve themselves. That's not something caused by medical schemes. They've also argued that medical schemes are somehow taking providers away from the state. There's no evidence of that. There's no analysis that I've seen, and I've extensively analyzed the human resource issues in both the public and private health systems in South Africa. And one thing is clear, there's not enough data. And number two, there is no indication whatsoever that the private sector is taking resources from the state. So the idea that you have to close down coverage in the private sector side in order to enhance benefits offered through the state is not true, or there's no evidence to show it. And for that, this kind of scale of intervention to be considered, you have to demonstrate this, and you have to put that to Parliament. And if you haven't put this to Parliament, how can Parliament make a decision on what's right or wrong if they have no evidence? if one just has somebody's assertion. So this basically is a serious problem when you talk about government having leapt forward a little too quickly. They've leapt without having done what is normally done in a standard policy cycle, which is a policy appraisal, an analysis, a diagnostic, a set of analyses on policy solutions. All of these things you would normally do when you look at a policy of this scale. None of it has been done. And so the issue is, yes, they've rushed forward. There's no clarity. They don't, even themselves don't appear to have any understanding of the machinery they would have to introduce, or whether at the end of the day they can in fact achieve these function shifts in the public sector and actually constitutionally close down coverage in the private sector and assume that they're going to get a better result out of at the end of the day. So this is of the concern. This is why people have raised all these issues. So much is up in the air, and so little work has been done. But people are absolutely in government, in the Department of Health, so sure that this is actually going to be a positive result for society when they actually don't have any evidence whatsoever to show for it. Neesa, your sound is off.
Sorry, it's almost like they want to make sure it'll work, but they're not quite sure how it's going to work themselves, and they're going to iron out the details later. Touching on that issue you were talking about just now, Alex, you touched on several things when it comes to staffing and the idea that the private sector is stealing positions away from public sector or stealing resources. I assume you mean like, doctors and nurses and that kind of thing. And I believe we've seen polls recently that have said that up to 35% of medical professionals are now thinking of leaving the country in light of the introduction of NHI. Why would that be, and how does it affect medical professionals? Because the idea, I think, is that NHI as a fund will pay all of them.
Yeah, so part of the problem that this kind of reform with so little, real engagement and evidence is that it's just generated massive uncertainty. And although it's very unlikely that many of these things will be are achievable technically at the end of the day, in other words, people can just wait it out and wait for the stuff that can't be done to become very clear to the implementers. The problem for people on the ground is they've got their careers, they've got their life path that they're interested in. That's one group of professionals. Now, that's when we focus on the healthcare professionals. So we could actually end up with a supply problem in South Africa purely because of the uncertainty created by this reform, in that people who are actively engaging in the South African public and private sectors might say, enough's enough. We're just going somewhere where I can have a predictable life. That's one group of professionals that we could lose. The other group of professionals we could lose are the people who actually say, I want to know that I can have a medical scheme. I want to know that I can be properly covered in South Africa to stay here. I'm an engineer, I'm a doctor, I'm a lawyer, I'm an accountant, an actuary. I'm, quite crucial to much of our economy are these highly qualified professionals who depend on and look in terms of their futures. I want to know that I've got a safe environment. I can educate my children and they can go to university and they've got healthcare. And I can control their access to healthcare because I'm not certain as to what the public sector can provide. So I want to have some control over that outcome. So those are a group of people who also look at this and say, well, maybe Canada, maybe Australia, maybe Europe gives me more certainty on all of those factors. And then we lose that. That becomes a supply problem to South Africa. We lose our engineers. We lose our key professionals. So this is a lot of uncertainty on the supply side of the professional class in South Africa, who one can say, oh, well, you're a privileged elite. But on the other hand, it's basically how this country functions. And we could lose those people too. So uncertainty is a very, very bad thing. It affects investment. It affects whether or not people feel there is a future in South Africa to invest in every sphere. And this kind of policy and the way it's been framed just has a great big question mark over it. And that's the worry. So yeah, people might just ride it out and wait for this basically reality to kick in. But some people say, oh, well, I actually don't have to. rides it out. I can create certainty within 2 years by going. That's the problem that this kind of policy proposal and framework does in South Africa. And I would argue it's got to stop. We have to have real workable policies in South Africa that make a change on the ground, in the public sector, in the private sector, and it's entirely possible and feasible. But instead, what we're doing is we're creating populist policies that have probably very little chance of being finally implemented in any form. But all it does is create chaos.
Absolutely. I think I have to smile because one of our listeners or viewers, Colin Lowe, says it's not so much a marriage as it is a kidnapping attempt. Craig, and on that point, somebody else has raised the issue. Medical schemes, as some of our viewers might know, they have medical scheme reserves, and you're required to have a certain amount, 26%, I think, is the solvency ratio that you're required to keep on hand. And there are apparently public concerns that government is looking to appropriate those funds. How realistic is that fear?
Yeah, look, I don't think it should be realistic at all. In fact, medical schemes operate under the Medical Schemes Act, and we have seen some efforts, even in this act, the National Health Insurance Act, to amend parts of the Medical Schemes Act. But we operate on a basis in which medical schemes are owned by their members. So at any behest of trying to claim those reserves from schemes, I think you'll find schemes challenging that very clearly in courts to protect the interests, and we have to protect the interests of the members. And so you can expect legal and court challenges in place. I would suspect that medical schemes will probably, as the worst end result, liquidate their reserves and pay them back to the members before they allow them to be annexed by the government or by the National Health Insurance Fund. And so I don't think it's a realistic thing that will happen, but we have seen stranger things before. But we will be prepared for that fight if it ever comes along, and I suspect it would be a long fight that we would win in the end.
And then in terms of the legal challenges, those I assume will actually be a stopgap in terms of, NHI is unlikely to be implemented or to move forward in any way until these legal challenges are resolved. And with 6 legal challenges in the room, and possibly counting, I don't think we're going to see the introduction of NHI anytime soon. Alex, what are your views on that? I know National Treasury, Mark Vetcher, has gone on record saying it's unlikely to happen in the next three decades.
Yeah, so first of all, this idea of the introduction of a system of so-called mandatory prepayment, whatever that is, I don't know what that is. Because you can only ever finance an improvement in the public health system, which is what the NHI fund will be. It's basically a fund in the public system, and it will be directing its funds through a public health arrangement. It's an intermediary to provide healthcare providers. In theory, it will buy private sector. It will include private sector providers in what it purchases. So the first issue is that there's virtually no possibility of a tax increase. And it's important to understand the logic of taxes, because they called it a mandatory prepayment. Now, you can consider a contribution to a medical scheme as a prepayment. It's a quid pro quo. I pay and I get access to a benefit. That's a prepayment. That's what is typically understood. A general tax is not a prepayment. A general tax, let's say 75% of what is spent in the public system is actually contributed by medical scheme members, but they don't access that. There's no benefit for medical scheme members for their contribution to the public health system. They are effectively excluded from the public system through the means test. They will have to pay for every service that they receive in a public hospital. That's basically how the uniform patient fee schedule has been established in the public sector. Medical scheme members are excluded. If they don't have medical scheme cover, they will be paying for public hospital care out of pocket, which will bankrupt many people. So that's the logic that currently exists. If you want to introduce a new tax to fund anything, you depend on the tax basis that you access. So in the case of the public sector, it's VAT, personal income tax, corporate taxes, and then a bunch of excise taxes and smaller sort of rats and mice taxes and revenue sources. The reality is that each tax base has a ceiling. And that means that there's a point at which when you increase tax rates beyond a certain point, it basically, people become less, they try to evade and avoid it. And what's often not fully understood about tax systems is that they really depend for their stability and sustainability on a very high degree of voluntary compliance. You might think it's not voluntary, but the moment you start to increase tax rates beyond a certain point, people start to think, how can I avoid paying this? Because they get nothing back for it. Medical scheme, you get something. You don't access the benefits unless you pay. That's not how the public sector works. And that's not how general government works. So the point is that government cannot just increase tax rates and expect that revenues will just flood in. Doesn't happen that way. And they can't say that because we see that medical scheme members are actually paying that money in, that means they're willing to pay a higher tax. No, they're not. It's a very, very fundamentally different tax base, and it's based on a willingness to pay principle because there's a quid pro quo. So you're saying, yes, they're prepared to pay a medical scheme contribution because of a quid pro quo, but they'll also be willing to pay a general tax with zero quid pro quo. No, they won't. And so the problem is tax dynamics enter into the system. So that there will never be any possibility of increasing taxes equivalent to 3.5% tax rates to achieve a revenue inflow of 3.5% of GDP. It is impossible at this point in time, which is why government hasn't done it. When it's basically the debt to GDP ratio has increased because government is constrained in its tax revenues that it can introduce. And there is very little possibility of just increasing tax rates without a destructive effect on tax revenues. So this is the problem. It's actually an absolute block on additional revenues. So this idea that you can just extract or switch the payments from medical schemes to government that's why it would have been useful if somebody had actually done a financial appraisal of this proposal, because then you would have hit this and said, oh, well, that's our constraint. And then you design your overall policy solution taking into account this constraint. They haven't done it, and they just pretend it's not there. So this is currently, I think, the big constraint in going forward with this overall framework. It's just not feasible to do this. And that's why National Treasury is making those comments. But there's another part, and I'll just quickly indicate it, because for this fund to have 2 cents to rub together, it also needs to shift the funding from provinces for provincial healthcare to the national level of government. This is not in the Act, by the way. So there's nothing that allows this. This is, first of all, that's a huge fiscal restructuring. But it's important to note that constitutionally, healthcare is a concurrent function with national government. Both national and provinces have this as a potential function. But what that means is that provinces have a substantial degree of autonomy in terms of the constitution. And currently it's funded by a provincial equitable share allocation and conditional grants, which go to provinces as revenue. And the provincial governments appropriate that revenue to healthcare. Now, you want to change that and keep the money at national. This is a whole recalibration of the entire national provincial financing system without changing the constitution. So your idea of achieving a function shift is not to change the constitution and the concurrent powers of government, but just to take their money away and circumvent the constitution. Well, obviously, this is going to be something that's tested in the courts when somebody attempts to try this. But this is also a bridge too far, because it's a massive transition. And then when they also talk about express function shifts, provincial, not in the Act, they talk about it as stuff we will do. Academic hospitals, provincial tertiary services, and regional hospitals will effectively, through regulation somehow, be function shift to the national level of government without any assessment having been introduced, because there's a requirement for technical appraisals for function shifts in government before they are permitted to happen. No such appraisal has ever been done. But this is, the entire framework is premised on being able to do this. So you want to switch all the provincial hospital services, provincial, tertiary, regional, and academic hospitals to the national level of government. and shift the provincial equitable share allocation and all conditional grant allocations to the NHI fund, and switch that so the public, any remaining services at a provincial level are all channeled through national government as reimbursement mechanisms, not budgeting mechanisms, not transfers, but the way medical schemes pay private providers. A public hospital will now receive this as reimbursement, not a budget. So all of these things are enormous changes. So on the one side, the financial appraisal should have considered the logic of being able to shift medical scheme funds across to the public sector. On the other hand, the financial appraisal should have considered the shifting of the provincial allocations to national level of government, which is a massive undertaking with probably no productivity improvement possible as a consequence of that shift, which would have to have been assessed in an appraisal. So these are all the things that are proposed in this, but I'm afraid they're potentially beyond the capability of government and basically shouldn't be done.
So I've got a few listeners who have come in and commenting that I think we've all gone to the polls yesterday and we've all done our democratic duty and put our votes in, and now we're waiting for the outcome of those election results. And a few viewers are saying, you know, there was this widespread view that the signing of the NHI insurance bill into law was an electioneering ploy, with little to no chance of actually being implemented anytime soon. If the status shift widely enough that the ANC is no longer the majority ruling party, and it's looking like that might be the case going forward, is there a possibility or is there a high chance that this could be walked back?
Who are you posing it to? Sorry.
Yeah.
I think, Alex, you put it, but I don't know if Craig wants to give it a shot.
Yeah, so I put my public policy hat on and say that this was clearly an electioneering issue 2 weeks before an election. You can promise stuff and that you don't have to deliver, and then people can find that out afterwards. But in terms of how the election results might impact, it might be, first of all, not necessarily just what happens at the National Assembly level, but what happens at provincial governments, because we are likely to see coalition governments in several provinces now outside of the Western Cape. And those coalition governments are not necessarily, part of these proposals are to shift the academic hospitals and the provincial tertiary hospitals to the first tier of government. It's not in the Act, but it's the intent ultimately to control everything from the national level of government. And as it stands now in terms of the Act, interestingly enough, participation by providers, whether public or private, in the NHI fund, in terms of contracting with it, is entirely a voluntary matter. There's no compulsion. It's clearly the intention to indirectly compel by taking the money away. And in the private sector, also taking the money away. So you have nowhere else to go but to contract with this fund. So now the question becomes whether or not provinces under coalition governments are going to be willing to allow the functions to be transferred to national. I can't really see it happening, because part of the reason why you win a provincial government is that you've got something to do. The idea of this act is that one of the two big functions that provinces have, healthcare, and in particular within that healthcare is academic hospital functions, provincial tertiary services, and regional hospitals. That's a lot that provincial governments have to show that they are effective and functional and capable of doing things. Now you're saying, I'm going to give all of that to national. And so I'm going to be left with basic education as the only thing that provincial governments do, and a bunch of other rats and mice. So the possibility is that if Gauteng is under a coalition government, it's going to say no to that. They've got 4 academic hospitals and a huge number of provincial tertiary and regional hospitals, and they will say, no, we won't contract, we won't move, we won't allow this to happen. So it doesn't matter what you pass at the national level, they've actually got the powers to say that. Nothing overrides that. And the same in KwaZulu-Natal, and definitely the same in the Western Cape, which has a very significant number of academic hospitals. So these are the provinces with all the academic hospitals, most of the academic hospitals and provincial, tertiary, and regional hospitals. And if they say no, then there's nothing in the NHI fund or nothing at national level that moves across. They're also in a position to, in those 3 provinces alone, to say this inconsistency, this mixture of an unclear mixture of powers between national and province in terms of district services. They're also entitled to say, we're going to continue to run those as we see fit. You can put whatever administrative functions you want at the national level of government. We just don't have to listen to you. That's potentially possible, even in terms of this framework. So that's what coalition governments would be, which means that you might be left with Eastern Cape who's willing to transfer their single academic hospital to national level with all of its contingent liabilities resulting from medico-legal cases. And Mpumalanga and well, that only has some regional hospitals. So these are so this is part of the issue, is that in fact the election could impact quite significantly on the relationship between provinces and national, even if ANC, for instance, forms part of a coalition structure at a provincial level. The other partners are probably going to say, we don't want to do this, and are unlikely to cooperate with a national government that basically wants to take their sort of prized assets away.
Perhaps, Neesa, I could just perhaps I could just add to that. I mean, I understand that the act is now signed, so it still needs to be proclaimed. And so in that process, there may be significant delays. And we saw, or history shows us, even the National Health Act, not National Health Insurance Act, that many parts of it were never proclaimed for many years. And so there is a possibility that that would happen depending on the leadership in the government. But I do want to go back to one of the questions that seems to come up quite often, and it is a reference back to the resources and the doctors and specialists that are in our country. I mean, the question is that we produce so few. In fact, many are leaving almost as they finish their community service year, or I know many that are actually writing the overseas board exams while in South Africa, just in the event that they could leave. And it's not a matter of creating a suspense about whether these people would leave. We've heard SAMA and others research as well. The missing part to the NHI has always been the fact that there's not a proper value proposition in place for those that will work and eventually work for NHI. And it's that insecurity and anxieties that we need to dispel up front to actually indicate, because of the time that it's going to take, you don't have to worry about that part of it. However, we do know if we hadn't been speaking about NHI, we probably would have been speaking about the fact that worldwide, COVID left a big gap in healthcare practitioners as a resource pool worldwide. And it is almost viewed that way. And so what we have to do is make sure that we are training more and retaining more of this pool to make any healthcare system work into the future. It's probably one of the big constraints that we've seen in the medical scheme space is the availability of even those healthcare specialists and the ability for the few to charge that much more because there's so few of them around and you don't have much choice or alternative choice in place. And so we have to actually do better at delivering, building and maintaining these type of skills. The UK came out a year ago and said they're looking to recruit 65,000 doctors in the next 5 years. We know they don't produce sufficient to actually replace, and naturally they come to developing countries in general to actually recruit. And that's why when you put NHI into the whole mix, the overseas attractiveness becomes a very real alternative for many of our providers. And we don't need that. We don't have the right, in totality, we don't have the right ratios of providers to healthcare consumers or population groups in South Africa. So that all we need to manage so carefully. To throw NHI in the mix doesn't help the process at all.
So I think there is quite a lot of outcry from the public and even from the private sector, and even some from the public sector about, the concerns around this act and what it means for the country at large and the public and people. Graham raises a point, and Craig, I'm going to throw it to you. He wants to know what is being done to plan to forge a unified opposition. So in light of the fact that the HFA is one of 6 different parties with a legal challenge, are those different parties looking at putting together a single legal challenge under one umbrella, or is it just going to be lots of legal challenges?
Yeah, so the medical scheme associations, there are 2 of us in the marketplace. So we look after half the medical scheme population. And so we do anticipate that when we talk about the private healthcare sector, medical schemes have a very particular part of the Act to challenge in terms of Section 33. And so it's and the single funder model in Section 2. And so there are these parts of the aspects that we will focus on. We absolutely accept that there are other parties with different interests, even though they are in the private healthcare sector, which may challenge many of the other parts of the Act as well. And so our understanding from the legal advice we've received that there will be an opportunity and a very real likelihood that the courts or even the Constitutional Court will put like-minded challenges together. And that it will be seen as one single challenge. And so we'll have to navigate that and see exactly, I guess you have to wait for the papers to actually be submitted to see the slants and nuances on each of those challenges. But that's going to be, I guess, the journey for the next few months.
And then one of my questions is, what does this mean for example, private hospitals in like the Mediclinics and the Netcares and the Life Health Cares? What does this NHI Act mean for them? And to piggyback on that, because we're running out of time, if I, as a private, I'm currently on a private medical scheme, and if I had to contract cancer, and even with a medical scheme coverage, I might not be able to get access to, I think it's called biologics in the oncology sector, you know, those fancy cancer drugs that are super expensive. Now, let's say NHI comes in. Is my option then that I've got to go fly to the UK or somewhere to access the level of healthcare I need?
Yeah, I think the risk is that the Act is written in the way that if treatment for the different cancers are included in the benefit descriptions of NHI, that if you aren't going to use NHI, you'd have to pay for them out of your pocket. You'd have to pay for them as either a non-user or somebody who hasn't followed the protocol of the NHI. So you'd have to fund that out of the pocket. You may still have access to that in South Africa, depending on what it might be. But yeah, overseas cover may be a long-term solution. But I think you're already stating that NHI will practically be in place and cover all these benefits, and that we don't know yet. So we don't actually know. We can speculate about what will happen and what may not happen. My own feeling is that that's why medical schemes will be around for a very long time, as whether it's described as complementary cover, it will just be that the affordability available for those benefits described in NHI is going to be so little that medical schemes will cover the bulk of the benefits for a much longer time. Perhaps that's until we get added tax revenues and the economy starts to grow, and maybe there's a little bit more space to include more benefits in the NHI. So that'll be my suggestion, that I don't think it will happen in the long run, and that you would still get access to proper cancer cover through your medical scheme for the next few decades.
Yeah, and I would agree with that. As I said, there is some doubt as to what complementary coverage actually means, because it's not properly defined in the Act itself. My assessment is, well, that you require some sort of declaratory order from the courts to clarify what they mean. And if they mean it's just whatever your complementary cover is, just whatever the NHI doesn't cover, that's just the double indemnity clause. It basically says, obviously, you don't want you to be able to claim the same benefits from the NHI fund as you could from your medical scheme. So whatever is complementary cover is just coverage that is offered outside of the NHI fund. That is a potential interpretation of complementary coverage as it exists now, because it's such a vague section. All I'm indicating is that you cannot clarify that in regulations. You have to clarify that in the Principal Act, and they haven't done so. So the idea that you'd have to pay out of pocket, though, I think is questionable, and certainly would be unconstitutional if you have access to coverage through a medical scheme, and now you've got to go through the onerous route of paying out of pocket for something that you could easily access insurance for. Now, the other issue is whether or not, let's say in a medical scheme, you should be covered for things like biologics, etc. The Medical Schemes Act and the framework and developing that framework does allow for the continuous evolution of the prescribed minimum benefit frameworks. The problem is that government has failed to actually continuously review the prescribed minimum benefits. So the last set of PMBs that were submitted after substantial evaluation to the Minister of Health was in 2010, March. And since that date, he's been sitting with that report and has done nothing. There's been no subsequent review, and therefore part of getting universal coverage is making sure that the prescribed minimum benefit framework is as complete as possible over time, which could include biologics. But that is an engagement that you have within the industry, and it's a question as to whether or not certain biologics are already incorporated, because cancer is covered. So these are also areas where it's a government responsibility to ensure that that is clarified overall. But the problem is that the focus on NHI means they don't have to do any of this work. So this is the problem, is that in fact we need to develop both the public system and the private system on an ongoing basis, and NHI doesn't develop any of those issues. And you cannot take people's coverage away on the assumption that they're going to access it in another environment and then not give it to them. So and not be in a position to promise it. So these are all the problems that we have. So yeah, I don't see anything happening for a very, very long term in relation to this legislation, which would not be challengeable. The private hospital coverage, etc., is going to continue. Medical scheme coverage, major medical coverage is going to continue. And the government itself is nowhere close to implementing any feature of this legislation such that it impacts on medical scheme cover or even provincial coverage.
Absolutely. I think if I had to just sum up everything we've said, I think the takeouts for our viewers would be that NHI might have been signed into law, but it's unlikely to be implemented anytime soon. There is no funding mechanism in place. There is no clarity about how it's going to work. And I think the bottom line and the most important thing for me to say would be, please don't resign from your medical schemes, because you really do need them and they're likely to continue covering you for years to come. Craig, do you want to add some final thoughts to that before we wrap up?
No, it is important that we provide that assurance to everybody that for years to come, medical schemes will be available to them. Just one of the answers that to a question that I also see in the chat is medical schemes are designed to look after members. There is no profits in a medical schemes, so any reserves that remain are there to pay for future claims. So if the medical scheme is liquidated, any reserves left go to the members of that medical scheme, and that's out of a design. So it's the best possible social compact process is a medical scheme. To get them larger and bigger and more efficient is an issue. But I'll probably raise one additional thing, is that healthcare is an expensive space. It's pushed by new technologies. It's pushed by burdens of disease. Even if NHI would be 500 billion rand a year, the growth in that from a year-on-year inflation is going to be inflation or payroll plus 2 or 3%. To finance that is a huge challenge. That's what we see in the private healthcare space. Our premiums increase by about that every year to compensate for those expenses. In the public sector, probably the queues grow because of that type of cost. What we have to do is find a better solution, and healthcare needs reform, but it needs the right reform.
Absolutely. Alex, any final thoughts from you?
Yeah, so on what we do require going forward, the point about health systems is that they are complex. They're not just complicated, they're complex. And staying ahead of the complexity of health system design and intervention is really an onerous responsibility of government. And the danger is that with populist sort of proposals along this line, you trivialize the complexity that you're facing. You assume it all away, and you create a sort of cartoonish version of a health system, and then pursue that while completely ignoring all the complexity that you're meant to be focusing on. And when you're focusing on that complexity, it's about the design of processes, the design of policies, sometimes on an incremental basis, occasionally on a stepwise basis, both private and public sector. You've got to deal substantively with cost increases. You've got to deal with human resource planning. You've got to deal with our actual mix of services that we have available in South Africa. You have to deal with harmonization between public and private sector functions and services, both funding and provision. You've got to deal with our whole academic function and our domestic research and its application. You have to deal with coherent systems for pathology and diagnostics. We don't really have a focus from a policy perspective on any of these issues, right down to organ donating. So the issue is, because it's this complex, it's not one or two services. You say health service, it's thousands and thousands and thousands of services. And that means you got to have ministers who know what they're doing. You've got to have DGs who know what they're doing. We've got to basically have systems and structures which bring the best minds across South Africa, not just in government, to address these problems and problem solve. We're not doing that at this point in time. So this is what we have to do. That's how you stay ahead of the game, not with weird and wonderful proposals.
Absolutely. I have to say, I feel like I've got a bit of a headache from all of this discussion and the mind-boggling problems that the NHI Act is bringing up for lots of people and lots of confusion. I'm sure I'm not the only one with a headache. I'm going to pop a panado soon. I wish it was as simple as that for all the solutions and the problems we've been talking around. Thank you so much, Craig and Alex, for joining us this afternoon. And thank you so much to our Daily Maverick viewers for listening in.